Hello, my name is Lachelle Moore, and I am a DNP student at Maryville University, and today I will go over my quality improvement project that is over utilization of a proactive rapid response nurse on the cardiac telemetry unit. A quick acknowledgement that Dr. Linda Studley was my chair for this project and completion. So first I want to go over what failure to rescue is. Failure to rescue is considered an unsatisfactory recognition of clinical deterioration causing unintentional and preventable harm or death. So when failure to rescue events occur in the hospital, patients generally get invasive procedures that they may not have needed. It can increase their diagnostic testing, which can cause another financial burden, and it also increases workload for the hospital staff. Failure to rescue is a national patient safety initiative that is assessed and monitored by governing bodies. And monitoring is a nursing task that is essential. However, these physiological decompensation events is still frequently missed if there's not appropriate training. Failure to rescue events are a problem because patients do deserve the right to safe and timely care while they're hospitalized. It's been shown that 84% of subtle signs, physiological signs, can show up to 8 hours prior to a cardiac arrest, which gives us as the healthcare team ample opportunities to intervene before this happens. Failure to rescue became a patient safety indicator in 1992, and so that's 32 years ago that it became a patient safety indicator and now an initiative, but yet there's still an ongoing development on the debate of what is the best measurement and method that's superior to prevent these failure to rescue events from occurring. In lieu of failure to rescue becoming a patient safety indicator, rapid response systems were created, which is a great option to intervene on these clinical deteriorating patients, but there are a lot of limitations to that. One of them being variation in composition. So compositions of a rapid response system can vary. So it can be nurse-driven, physician-led, it could be a dedicated team that is a function of people that don't have other job duties or patient load, patient cases, or it can be shared, each one of them having variations in escalation protocols as well. Rapid response systems are also underutilized because of a lot of nurses have barriers that prevent them from wanting to call or escalating patient care due to the stigma of needing extra resources or needing critical care expertise. And another reason why rapid response systems can fail is because of ill-defined team dynamics. Another factor that's problematic is inconsistency in monitoring techniques. The failure of the afferent limb of the rapid response system, which is considered the proactive surveillance portion, is generally found to be the most complicated. Screening and scoring tools that we use, such as modified early warning signs, which is the Muse scores, are used, but it's not consistent throughout worldwide. It makes it challenging for nurses to adhere to these types of requirements. So proactive monitoring or surveillance of this data may not be included in some hospital systems. The research question for my project is as stated. In hospitalized adults on a telemetry unit, does utilization of a proactive rapid response nurse compared to the patient's assigned registered nurse determining the course of action without a proactive rapid response nurse reduce unnecessary intensive care unit transfers post as compared to the pre-intervention rate over a period of 6 weeks? The purpose of this project was to decrease unplanned ICU transfers and decrease avoidable clinical deterioration, which is that failure to rescue measurement. There are also a lot of secondary aims included in this project, one of them being standardizing a rapid response team protocol, which includes a proactive monitoring component, which could be replicated in the future, which is an important aspect of this project as well. In addition to that, improving nursing compliance with Muse score or screening tool documentation as a standard of care at the site facility that this project was implemented was another shared purpose as well. Other aims included supporting novice nurses through critical care situations that they may not have been exposed to or knowledgeable about, as well as strengthening team dynamics with increased communication of nursing staff and providers to ensure improved patient outcomes occur. The initial steps prior to implementation that occurred was receiving IRB and site approval. For this project, I did require a second IRB proposal as my approval, as my initial proposal did change and it was modified. Following the approval, the Quality Initiative Project was determined exempt from human studies per the site facility. Ethical considerations were considered, such as their patient privacy and confidentiality, which was secured with additional safeguard mechanisms such as password protection on electronic devices, on-site access only for the anonymous and confidential data. And then data entry was de-identified and completed by proactive rep response members that were only accessible to those that were granted access to the facility. Data was then categorically placed retrospectively into an Excel spreadsheet by the scholar. The method of this project was quantitative in nature. It was additionally retrospective using archival data review of electronic health records. The facility that underwent this project was a large 590-bed urban hospital in the Midwest. It was a for-profit hospital. It had 44 ICU beds, and the ICUs were divided into 3 surgical, medical, and neuro ICUs. There were also 58 cardiac telemetry inpatient beds that patients could be admitted to. The pre-intervention data was completed for a 6-week period from November to January 6, 2023. The post-intervention data was collected exactly 1 year apart until January 6 of 2024. So the indication of getting the exact dates 1 year apart was to avoid any fluctuations and any confounding factors that might have been regarding to seasonal changes in the hospital admissions at that time. For this project, measuring failure to rescue events, we used the measurement of unplanned ICU transfers. There was a minimum of 154 participants that were required for that. Participants were considered if they were all hospitalized adult patients that were older than 18 that were admitted to the cardiac telemetry unit. There was no active recruitment for this project, and no additional consents were obtained. However, it is important to note that implied consent was obtained following signature of agreement of medical treatment at time of the admission by the patient or the DPOA or guardian. However, all participants were given the opportunity to deny participation of the proactive rounding. Prior to implementation, there were many steps that were necessary to begin. First, the rapid response system team policy at that facility required an update to reflect the new rapid response, proactive rapid response nurse process. The current rapid response team protocol was not adjusted, only the proactive portion was implemented. However, a nurse-driven proactive rapid response team protocol was created to demonstrate the afferent limb changes associated with the intervention that we were using. The protocol guidelines were approved by the nursing administration as well as the medical executive board. Once the guidelines were accepted, a job description was written for the staff that were being hired into this position. And alongside the protocol, a pre-approved order set was created to allow the rapid response system, the reactive portion, the actual efferent limb, to work autonomously within their nursing scope of practice. Then education was provided by the facility's education department, and orientation was provided to those that were serving as the proactive rapid response nurses prior to implementation. The inclusion criteria for this project was very simple. The patient needed to be 18 or older, be any race, nationality, ethnicity, or native language, but they must be admitted to the cardiac telemetry unit at the time that the proactive rapid response evaluation occurred. Patients then had to meet criteria based on needing a rapid response proactive rapid response evaluation. The primary criterion included Muse scores that were equal to or greater than 4. However, the rapid response nurse was a dual role in conjunction of a resource nurse job function as well. So there were other inclusion criteria that could have been utilized. The complete inclusion criteria included concern from the patient, the family member, or the nurse that requested additional assistance with clinical judgment, or failure to respond to provided treatment, and any physiological changes that occurred in the event that Muse scores did not accurately calculate or trigger an alert. Physiological changes included changes to any type of vital signs, mental status change, seizures, concern for acute stroke or chest pain, changes in urinary output, temperature, uncontrolled bleeding, wound dehiscence, and concern for multiple system organ failure. In the inclusion criteria, the rep response nurse was primarily to respond to patients that had a Muse score that was equal to or greater than 4. But since the role was shared with resourcing, there were other inclusions that were necessary to add in the event that additional help was needed. So that ranged from anything from nursing tasks requested through the resource section, as well as concerns for deterioration for the proactive rapid response nurse process. The exclusion criteria for this project included if the patient was admitted by trauma services, admitted to any other unit outside the cardiac telemetry unit when the implementation occurred, and if there were any exclusions determined based on incorrect or inaccurate data collection determined during the chart review. As part of the project design, the Muse scores were documented in both the pre and the post intervention phases. This picture shows a table of the physiological data that's recorded by the bedside nurse and how modified early warning sign scores are calculated in the computer. This information was documented in the patient's electronic health record, and only the score was included in the data collection. For this project, there were different data collection tools that were necessary. Since the pre-implementation phase did not include a proactive rapid response model, the rapid response activation log, which was in place prior to this project, was collected and reviewed to determine the calculated Muse scores during that time frame in that 6 weeks. The rapid response proactive rounding log was initiated when the intervention occurred, which also reviewed Muse scores. In addition to Muse scores, the patient's demographical information, admitting team, reason for admission, code status, interventions, time frame, and outcomes were also documented, which was reviewed. It was important to gather all that information regarding the utilization of the proactive rapid response nurse based on determining the activity of the trigger alerts, if the patient was evaluated by the proactive rapid response nurse due to a resource request, or if it was triggered by a Muse score. The third data collection sheet is the ICU throughput list, and that was a form that was completed daily for both the pre-intervention and post-intervention phases. That sheet determined the number of admissions or transfers and discharges, but that wasn't calculated, which occurred in the ICU. So the importance of reviewing the ICU throughput list determined the rate of how many unplanned ICU transfers occurred from the cardiac telemetry unit for both pre and post implementation phases. The independent variable of this project was the utilization of the proactive rapid response nurse in comparison to the non-utilization of a proactive rapid response nurse. And the dependent variable, again, was the rate of unplanned ICU transfers from the cardiac telemetry unit. The null hypothesis was noted as no change. Information was gathered from the data logs and the ICU throughput list, and this table demonstrates the number of total ICU admissions or transfers on the left column, and the number of unplanned ICU transfers from the cardiac telemetry unit on the right column. So each section is divided into the 3 ICUs, medical, surgical, and neuro, since there were all 3 ICUs were evaluated. And as you can see in this table, the total number of unplanned ICU transfers for both the pre and the post-implementation phases was 6%. That is highlighted in yellow. Therefore, this project accepts the null hypothesis. And this table is the most pertinent regarding the results because it is the measurement that we used for failure to rescue. This table denotes the hypothesized difference that would be 0 for each ICU. The sample sizes are divided by unit as the total number of transfers or admissions which occurred for the selected time frame. Number of items of interest were the amount of the unplanned ICU transfers that occurred during either the pre or the post intervention phase. Using a lower tail z-test of the difference of 2 proportions, you can see here on this slide that the p-value for each surgical, medical, and neuro ICUs is greater than 0.05, which demonstrates that no statistical significance occurred with the intervention. Another important result throughout this project was the results of the MUSE, the Modified Early Warning Signs score documentation collected with this data tool. To trigger a proactive rapid response nurse to evaluate a patient, the MUSE score had to be 4 or higher. That was a requirement. So as you can see on this graph, there was a significant amount of MUSE scores, which was about 23%, which were found to be missing, or it was resulted as a nurse request for resourcing, such as bedside nursing tasks. So misdocumentation included bedside nurses that failed to enter a MUSE score at all, or incorrectly into the EHR correctly, or not completed them at all. In this graph, which were rapid response nursing interventions, incorrect charting or no intervention was actually the highest intervention, which was 13 of the 55 encounters that occurred. The next highest interventions that were performed by the proactive rapid response nurse were medication administration, blood transfusion or IV fluid bolus, and respiratory workups. However, 6 out of 55 of the encounters were nursing assisted tasks, and 3 of the encounters were not documented at all. So to discuss this quality improvement project and its results, it is found that failure to rescue is a complex measurement, and it is impacted through several organizational and process methods that are within the inpatient setting. Implementation of a proactive rapid response nurse as part of the afferent limb has been shown to improve inpatient cardiac arrest rates, decrease ICU transfers, decrease lengths of hospitalization, and decrease in critical care interventions. In comparison to other studies, though, this quality improvement project did not demonstrate a statistically significant decrease in unplanned ICU transfers with the addition of the proactive rapid response nurse on the cardiac telemetry unit. However, there are secondary discoveries that are of value still. To discuss this also, even though a statistical significance was not determined, there are other supporting factors that are similar to other studies. Missing MUSE scores documentation or the lack of MUSE score documentation due to other rapid response duties were measured at 62% of all the scoring data for this project. So this does coincide with the other studies that indicate that insufficient nursing documentation is crucial in preventing failure to rescue events, as determined by the lack of change following this intervention. Smith et al. 2020 described that the primary influencer for an afferent limb failure is characterized by inconsistent staffing behaviors and the variables in the documentation. Many studies establish that the relationships between appropriate timing and the usage of automated MUSE scoring triggers, and reduction in the unplanned ICU transfers and inpatient mortality. So despite the MUSE scores system during this project, the average length of time from score to the proactive evaluation was still 108.3 minutes. The largest confounding factor in comparison to similar studies is that lack of electronic MUSE triggering system, despite the electronic health record documentation capabilities that this facility had. So the rapid response nurses were required to manually check the scores every 4 hours throughout this intervention phase, as opposed to it being automatically triggered, such as through a paging system with real-time notifications was initially part of the plan, but it did not happen. So scoring systems that are based on physiological data are a risk stratification tool to prevent failure to rescue events, but if it's not used consistently or without the proper equipment for the monitoring purposes, the result seems to be void. Another suggested finding of this project included the relationship between how the rapid response nurse, the proactive rapid response nurse intervention was utilized and the effects of decreasing the unplanned ICU transfers. There are many practical and clinical connotations that align with the restructure of the afferent limb of the rapid response system. So throughout other multiple studies, there are variances in rapid response system models and role descriptions of what a proactive rapid response nurse is determined based on the needs of the facility and what the staffing capabilities are there. As this was implemented, the role was considered shared. So the duties were not dedicated specifically to the rapid response team. 24% of the evaluations that were completed were due to the resource nurse role responsibility. So there's a substantial portion of the evaluations which contributed to this project's results. There was another similar study by Winterbottom and Webre in 2021 that used a dedicated rapid response nurse versus a shared role, which contributed to a 4.7 decrease in ICU admissions, as well as a 65% decrease in inpatient cardiac arrest. Another study by Danish et al. In 2019 used a dedicated rapid response nurse model to proactively surveil high-risk patients as well, and that resulted in a significant reduction in unplanned ICU transfers. So this finding, in comparison to this project to other studies such as those, may suggest that a dedicated member of the rapid response system would contribute to prevention of failure to rescue rates, even through less interruptions and maybe even requirements of other job functions. Lastly, the combination of the missed documentation or incorrect documentation that occurred, extended rapid response nurse evaluations, and dual job responsibilities of the shared role may furthermore be associated with inadequate education or training and allocation of resources to support this position. Comparably, many other qualitative studies suggest adherence to intervention is directly associated with preparation, education, and training, as well as unit culture, perception of the rapid response system, and nursing experience. Qualitative data was not collected throughout this project during the implementation, but there are some inferences that can be concluded that these factors contribute to the data results. But additional research is necessary to determine if the effects these factors on, if these factor into what the failure to rescue events effects would be. The strengths of this project included a large sample size with minimal excluded participants. This project was completed in a retrospective manner, so there was a pre and a post-intervention comparison to determine the efficacy of the change event. As only the afferent limb of the rapid response system was altered for the project, the efferent limb remained the same. So by only impacting one portion of the rapid response system, there was minimal confusion as far as what the participants of the staff were to do. As part of the afferent limb data monitoring, the MuseScore tools was previously utilized at the site facility and available already in the electronic health record prior to the intervention, and familiarity of its use and accessibility of the MuseScores into the EHR reduced the delay of implementation and planning for this project. So education provided on the required documentation during the intervention was review for them instead of it being new information for the staff. The limitations of this project was primarily related to the retrospective design, as there are missing data elements. Retrospective data also has potential for recall bias due to the fast-paced situations. So nursing staff is unable to document in real time, which can influence recall bias is when they're unable to document in real time. So it can affect the accuracy. And then the quality of data is crucial that limits the bias, to limit bias, as the medical records were a primary source of the data collection. The site was a single center. The project was completed in a single center in a single unit, so it also limits generalizability and decreases the potential sample size. Inconsistent coverage and staffing. The position was opened to 2 full-time FTEs or full-time equivalent positions already, but the position was mostly covered by ICU nurses that were staffed as overtime shifts, and it was deemed optional following the appropriate level training that they received at orientation. So following after the initiation of implementation, I wasn't able to review the vacant rapid response dates and the shifts in which could have delayed the proactive evaluations or entirely missed if the shift wasn't covered, and that impacted the utilization rate of the proactive rapid response nurse due to that inconsistent scheduling. There was also no evaluation of individual components as far as patient complexity, comorbidities, and indications that resulted in a proactive evaluation or a nursing resource request. So Muse scores were calculated prior to that resource request, which may have skewed results as well, providing a falsely low impact of proactive rounding, as the majority of Muse scores documented on patients were missing or less than the triggering score, which was a Muse score greater to or equal than 4. barriers to this project was a change in the initial project proposal, which went from a dedicated rapid response team to a rapid response nurse to a shared proactive rapid response nurse in conjunction with the resource nursing position. Staffing was a barrier. There was only 2 people that were full-time. Every other shift was filled with ICU nurses that picked up overtime shifts. A big deficit in this project was the track and trigger method, which was supposed to be an automated triggering method where it would send a page with the Muse score and the room number. However, the nurses, it was ineffective, and the nurses were, they had to manually go in and pull reports every 4 hours for every single shift throughout the implementation phase. And then also adaptation to the change agent was inconsistent because of the inconsistent nursing staff education. It wasn't very clear when the education went out, as the site facility requested that the information be sent out from them and not from me during this project, and it was pretty unclear at what point the distribution of education occurred. The facilitators for this project included the high amount of staff interest in improving the rapid response system, as well as the involvement that was occurred by the committees at the site, and having the Muse scoring tool already in the EHR for easy access and education. This project determined that a shared role is not effective for proactive monitoring. It also showed that there is such a high reliance of resource nurses to assist that don't necessarily include changes in physiological signs. The manual reporting was insufficient for proactive rounding, as far as manually obtaining a report versus an automatic track and trigger method. And Muse scores may not actually be an accurate representation of clinical deterioration of patients. Due to this project, it is evident that an automatic track and triggered method, which collects and communicates the early warning signs, is vital to the afferent limb of a rapid response team and proactive evaluation of patients. Although most studies use Muse as a system for physiological data, the superior early warning sign screening tool is still debatable and should be evaluated further. This project did not show a significant change in unplanned ICU transfer rates. This project also demonstrates how deficiencies in standardization of education of quality improvement projects do play a key role in adherence. This project also supports other studies which report education is a staple to success. Similarly to future research, implications on healthcare policy includes finding appropriate measurements of failure to rescue events, as well as creating a structured workflow, such as improvement in rapid response system protocols that may include a proactive monitoring portion. And then lastly, formal education is necessary to improve patient outcomes. For implications in quality and safety, this project demonstrates the effective communication from leadership on nursing empowerment and compliance with quality improvement tactics. Availability of appropriate knowledge and proper tools are necessary for safety of patients and the quality of care that's provided. The project results also demonstrated that both clinical judgment and physiological data are necessary to prevent clinical deterioration, since there was a significant lack of demonstration related to the unplanned ICU transfer rate. Nurses also need support and utilize the proactive rapid response nurse role as a method of assistance with various nursing tasks and additional evaluations despite the calculated Muse scores that were triggered. Nurses also need suitable education to ensure physiological changes are not going unnoticed as well. It would benefit future studies as well to ensure appropriate staffing ratios are maintained to obtain more accurate results, and the quality of patient care is grossly affected by these staffing ratios. In conclusion, it was found that poor proactive surveillance causes afferent limb failure, whether it be the lack of a proactive evaluation by a rapid response nurse or a calculated score that would trigger an alert. Additionally, providing nursing support regardless of deteriorating signs is important because nurses use this position to really resource for them versus helping with deterioration on the unit, and that the track and trigger method should be automatic versus manual, where they would calculate the report, determine the report themselves every 4 hours. And that concludes my project. So thank you for your time and looking over my PowerPoint. These are a list of my references as well. Thank you.